Hello and welcome to session 2 of this international forum. I'm Anton Pozniak, a physician from London, and this session is called Towards Achieving the 95-95-95 targets in Asia Pacific. And it's with great pleasure that I introduce Mr. Eamonn Murphy, who's a regional director for UNAIDS in Asia and the Pacific. He had senior and important roles in the Australian government around HIV and AIDS, and then worked both in Vietnam and in Myanmar. And Mr. Murphy is going to talk about achieving 95-95-95 implications for the region. Over to you, Eamonn.
Thanks very much. I'm very happy to be with you here today. We're going to look at where are we at in terms of the response to HIV/AIDS in Asia and the Pacific, and what needs to be done to achieve the new targets of 95-95-95. So where are we? Globally, there's a decline of 31% over the last decade. In Asia and the Pacific, it's 21% decline. And of course, that hides a lot between different countries and the pace of change. But as you can see on this slide, we're still a long way from achieving both the targets for 2020 and, more importantly, 2030, when we're supposed to achieve the new targets. So there's a lot of change required if we're going to seriously achieve the goals of the new strategy and the agreements of member states in the new political declaration that was just agreed this year. So where are we at for the region? The latest data tells us where new infections are occurring. This means program change is required. 53% of new infections are occurring among men who have sex with men. Yet many countries have not got the right type of programs in place to focus on this population. And there's increasing stigma and discrimination that is a barrier that needs to be overcome. You can see second to this, people who inject drugs. Similar negative responses on this, rather than the proactive public health responses required, which both address HIV and the intersection of drug dependence. And so having a different approach to this area would be critical to success. Sex work and other areas, we've seen some improvements over time. And you'll see this throughout the presentation today. Here, young people is the other critical new factor we need to look at. We have new wave epidemics. In some countries, you could talk about two different epidemics, the long-standing older epidemic and a new epidemic. Look at the figures here in the top left column. In the graph here, Philippines, 216% among the young in the last decade, and that's largely in the last few years. And other countries from Malaysia across, and you can see the increase is continuing among young people. The bottom left quadrant, you can see where are we at against the regional average, 26% across the region, and you can see where countries are above that in terms of new infections amongst the young. So that means new approaches, new ways of reaching young people. Young people do not respond to the old established programs. They live in a whole different way and a different lifestyle than we did. That's the internet, it's mobile technology, it's different social networking. These issues need to be adjusted. The top right quadrant, you can see the pace of change, and it varies across different countries, just as examples. One of the biggest barriers for young people to know their status, to be able to engage in protecting their own health and understanding their health issues, is that for many, they can't access health services without parental consent. And you can see there has been some improvements recently with countries giving either access without parental consent in the case of 17 countries, or reducing the age that people can access, young people can access services without parental consent. But we still have 14 countries, or 37%, where it's 18, and people are very sexually active in a number of places before that, or taking other risks. So they need to be able to engage in protecting themselves and understanding their health. So this is a critical barrier to many. Pre-exposure prophylaxis is a critical new thing. I'm sure you're all familiar with it. Where are we at across the region? We've had substantial change in recent years. And there's a partnership with the World Health Organization and UNAIDS, where we've co-financed technical support across the Asia Pacific. a significant way of bringing together different agencies with their expertise, and more importantly, the national partners we're there to support. But when you look at this, and you can see by the color coding, where PrEP, if we start with planning, there are a few countries still planning, some have started piloting or just post-pilot, but even at the national scale, when you look at the yellow dots, what level of scale? And that's the critical difference. Just saying we have a PrEP program doesn't mean much if we don't see the scale of coverage and service availability. So good progress, but still a long way to go. This is a critical new tool. We've seen the evidence from many countries in our region, from Australia to other countries like Thailand, Vietnam, where they're seeing reductions in new infections. And so this is a critical area of new intervention that needs to continue to increase. Lagging behind overall, though, on prevention. And you can see in this graph, the 95% target, the new target. Where are we? Only Cambodia has reached that for female sex workers and gone above it. Cambodia is doing well. For most groups, men who have sex with men, though, are lagging behind. And you can see the red dots on the left of the 50% mark, and the majority of the countries are way below that. Thailand's on the border of it. Some programs for sex work, better prevention programs, but the rest, we've still got a long way to go, and this is a serious challenge. This needs significant impact and program design change in countries to get prevention to move forward. Testing. Similarly, we have some challenges here. Testing has been improved overall, but you can see across the key populations, where are we at? And where are the groups that are lagging behind? So the data is available to countries. We have detailed information by country that can help them understand where do they need to lift? Where do they need to focus their efforts in terms of getting key populations into testing? Because there's a whole range of benefits from testing, knowing your status just to know for your own health's sake, knowing then about treatment options and how that can benefit you and your family and the community. Types of testing. This is where we're working with a range of partners, and we need to see increased change. Community-based testing is available. In the past, testing was largely about counting numbers, and so it was strategic information data gathering. But the program implementation of it is increased. The community is critical to it. The lay providers, it drops down. And again, self-testing. In this era of young people who live their lives on the internet and using mobile technology and virtual space tools, we need to give them the tools. The other issue with self-testing that makes it a critical area for investment and change is that with stigma and discrimination as a major barrier for many people at country level, they don't access services, fixed site services. Their fear of being identified by a risk behavior or some issue in their life that is socially unacceptable, that stops them from accessing. If they can test at home, then that engages them with the health system. And there's great examples from India across many different countries of where this is working, but we don't have anywhere near the level we need. And social networking also is another area that we need to see increased work, where the networks themselves, and this is again, particularly for the young and marginalized populations, where they can communicate amongst their community about the needs. So the gaps, to summarize, when we look at the targets here, we have over 1 million people still need to know their status. So we're a long way from achieving the testing to start with. And then we move into getting people who are tested into treatment. And there is a big drop-off. And this is a challenge for a number of countries. And there are a targeted number of countries that really need to get that connection. So what's the barrier holding people back after they know their HIV positive status of getting into treatment? And that needs to be addressed. It's the structural barriers that hold people back. Stigma and discrimination, access to treatment. Cost is not the barrier in most places now. So there are issues here around the service environment. Viral suppression is really important because we see the long-term benefits to the individual of their own health, but also then protective benefits that are well understood now with U equals U, and we'll come to that. So achieving viral suppression is critical. Access to testing services is a major part of that, the viral assays, so people understand it. So there are gaps, some positive progress, but we've got a way to go. On the right, you can see by young people, by women, and by men. Dolutegravir is a critical tool in terms of treatment, and this is because it's more effective and has a benefit. But you know, when we look at only 11 countries have introduced it as part of their first-line regimen, that's only 29%. We're still a long way to go. Some have it as an alternate, but it should be in the first line for all countries. And we even see 8% it's not included as all. And others are still not clear on the placement, haven't reported it. So, but we have a big gap here, and it started, it's in plans, it's in programs, but the implementation is behind for our region. The drug resistance is an issue with this, because we see on the left of this, all first-line ART initiators. And where do we see drug resistance? Look at P&G. High levels of drug resistance. And then on the right for P&G, you look at people who are drug naive, 12.3% of first-line people accessing treatment for the first time have drug resistance. So that means there are strains of resistance building up in the community. Prior ARV drug exposure is an issue. That means there are gaps in people's treatment program. So they're either not able to access the treatment in a continued fashion, and supply is a challenge for it, or service delivery challenges. P&G, 42%, that is so high. And so you can see these are examples for the region. Dolutegravir is a major part of how this can be addressed and improved. So that's why it's critical. HIV and COVID, significant intersectionality issues. And you look in the column in the middle here, and the same issues that we've been dealing with for so long on HIV are major barriers and causing impact of COVID to be more substantial for individuals in communities, be that their status around income and access through employment, you know, issues of access to healthcare and insurance, you know, incarceration in prisons and detention centers, you know, laws, local policies that give preference to some over others, the same issues we've been dealing with HIV. That's why you'll hear in the new strategy, the focus is on these issues of inequalities and addressing those. They're critical both for COVID as they are for HIV. What's the impact for us of COVID on HIV? Look at the access to ARV, the treatment scale-up. 20 across the Pacific, Asia Pacific, you can see there's a reduction of net increase in 2020 compared to 2019, and only 5% increase in the last year in access to treatment. So service interruption, program interruption. Look at Pakistan, Timor-Leste, the Philippines, India. Major interruptions between the programs that they had in place, and you can see it across the board in many countries. So COVID has had and continues to have a direct impact in both prevention, but here importantly in treatment scale up, and that's critical if we're going to move forward with achieving 95, 95, 95 targets. There's also been great innovation across the region. Some examples here for you to consider. You know, this includes multi-month dispensing of ARVs, differentiated service delivery. So that's reaching to people in their homes rather than having them come to high-risk fixed sites where their risk of COVID is an issue. There's been opioid substitution, take-home doses increased in a number of countries. That's a critical tool. PrEP programs have got around this challenge. You know, our community networks have been sharing examples amongst themselves across the region and globally to show that these programs can be done. Critical importance will be that this is maintained as we work through COVID period and onwards, because this will have a major impact in achieving greater and faster outcomes for the new targets. When we look at the targets themselves, this is a really important thing. Member states have come together through the global strategy on AIDS, but also through the high-level meeting and the commitments they have made in June of this year to achieve the new targets. We didn't achieve 2020 targets for our region, so we need to see that change that's going to achieve these targets, the 95% targets for the key areas of the program. But in addition, there are the 10% targets, and these are critical. 10% of countries having punitive laws and policies. So that means a significant reduction in our region for some countries with punitive laws. Less than 10% of countries experiencing, or the communities experiencing stigma and discrimination. Again, major structural barrier that we're facing across the region, and it's growing in some places. And less than 10% of people experience gender inequality and violence. Another reason why HIV has to be part of a broader agenda focused on inequalities. The inequalities lens is at the center of the new global AIDS strategy, and that is critical to us. When we look at these issues that are holding back the responses in many of our countries, it's about the institutional barriers. It's about the stigma, the discrimination, the service access. And so that's why the inequalities, and if you recall the slide that brought together the two of COVID and HIV and the central column of these inequalities, this is critical, and that's why it's at the heart of the new strategy, and that will change the way UNAIDS and many partners will operate. And that's what we need to see change at country level. Let's address the inequalities, because that's what's holding back prevention, it's holding back the testing, it's holding back the treatment access. Moving forward, what do we need to see? The scale up, obviously, of combination prevention led by key POCs, particularly the young engaged in the program design and delivery, PrEP, the self-testing, transition of treatment to dolutegravir, in the first line, same-day ART, multi-month dispensing. A lot of this is known, but we're not seeing the pace of change fast enough. The differentiated service delivery, that we really need to see continue, and the examples given as part of COVID is a critical way that we can see that this can really make a difference. Non-traditional partners are going to be critical for universal health coverage, as they are for HIV, and we need to see the role of community. The sustainable financing, the engagement of community, the inequalities issues of addressing stigma, the barriers, women's rights, empowerment issues, all the issues that we're very familiar with, people-centered approaches, looking at human rights and innovation. Our targets across the treatment spectrum, we need to see that change, and that means getting people tested and getting them straight into treatment. And importantly, working on viral suppression. I've taken the time to put up here for you to consider U equals U, which is a new concept for many, but a critical one for a whole range of reasons and benefits. Be that for the individual who once they realize that being on ARV and achieving undetectable levels, and that's where the viral suppression, that the testing is important, viral testing is important, that means they are not going to transmit HIV sexually, and that's clearly understood. WHO, many like the US Centers of Disease Control and many other partners across the globe have proven this is evidence-based. Accessing treatment as soon as they're diagnosed and retained in care is critical for a number of reasons, but also because it will motivate when people realize that if they achieve viral suppression, undetectable HIV, they can't transmit. It makes a big difference to how they see their futures and how they can see themselves and their families continuing, and they'll live the same lifespan as the average person in society. So, but they will need increased access to viral load assays at affordable prices. So countries need to work together to look at how the prices can come down and making lab systems more effective for this. Combination prevention needs to be a key part, and the whole issue of U equals U needs to be brought into our prevention program to understand the benefits of treatment for prevention in this context. So to conclude, we need to reach people. And in this environment, let's think about those hidden key populations, particularly the young who are online. How do we reach them? How do we find them? That's changing the nature of our program. Differentiated approaches, the interventions that need to be scaled up, and the scale is critical, not just introducing them, but scaling them up to the right level. Integrated packages of services. The role of the community in program implementation, the right structures. This is UHC, universal health coverage, requires strong community participation to achieve its outcomes. Pursue data-driven approaches, look at the financing, the policy, the institutional barriers, those inequalities of stigma and discrimination, the rights that people are not able to enjoy and keeps them away from health services, including HIV. Violence in society, and ongoing in the immediate period, the next few years, COVID and the challenges. We've seen adaptations and successful programs with this. We need to see that continue and scaled up and maintain, particularly these innovative differentiated service delivery models and multi-month dispensing, and a significant increase on these. I hope this has given some ideas, food for thought, the discussion, and during the course of the program, you'll hear from many different partners and giving good examples from country level on how they are responding to the changes that are required. Thank you very much for your time.
Thank you so much, Regional Director, not only for the overview of what's happening in the region, but also for the plan forward to achieve these 95, 95, 95 targets. And now we move on to upscaling of laboratory services and novel rapid diagnostics, this extremely important topic. We're going to hear from Professor Pascale Ondoa, who's from the African Society for Laboratory Medicine, ASLM, in Ethiopia. Professor Ondoa has worked in Antwerp with the Tropical Medicine School in Belgium, and is also affiliated to the Amsterdam Institute of Global Health. And she leads as Director of Science and New Initiatives of this ASLM. She's helped develop alternative ways of testing for HIV, and she leads several projects and programs looking at trying to address gaps in laboratory systems and networks in African countries. And it's with great pleasure that I introduce her to you today. Over to you, Professor Ondoa.
Good morning, good afternoon, or good evening, depending on where you are. I would first like to thank the organizer of this meeting to give me an opportunity to present the experience of the African Society for Laboratory Medicine in scaling up laboratory services to achieve the 95, 95, 95. I declare no conflict of interest. So this presentation is going to focus especially on viral load. I acknowledge that there are other testing that are important for the 95, 95, 95, but viral load is really an interesting case study and is specifically a key to the third 95. And if we go back a little bit in history, we will see that the WHO guideline for antiretroviral treatment in 2013 recommended to use the viral load as a preferred method instead of the CD4 count to monitor the treatment effectiveness. Then in 2016, the guidelines recommended that all HIV positive persons should receive the treatment, and the UNAIDS fast track targets, number 3, recommends that 95% of the patients receiving treatment should be virally suppressed by 2030. So due to this recommendation and the target of the UNAIDS, there's been a sharp increase in the number of people in receiving treatment in Africa, a 200% increase from 2010 to 2018. And there's an implication on the number of viral load tests to be delivered to this additional number of persons. An interesting fact about the viral load is also that it is a testing that is often used as a gateway to differentiated service delivery by allowing the triage of patients, which would be differentiated between the stable patient with suppressed viral load that can then be referred to less intensive care at community level, and unstable patient with high viral load that need to be referred to intensified adherence support, advanced disease testing, for example, and clinical packages for to manage comorbidities. And that's important to avoid the overload of the HIV care services. So what is the progress of the viral load scale up? And I'm showing you the case of 7 PEPFAR supported countries. And these are results that have been published at Dr. Lecker for the US CDC in 2021. So PEPFAR worked and shows the result of those 7 countries that you see on the left, and they compare the number of patients before the scale up with 2018 when the scale up of viral load was really well on the way. And we see a sharp increase in the number of patients that are receiving treatment in those 7 countries, between 50% for Lesotho and 70% for Namibia. And now the question is, can the viral load really take up to manage all of these additional patients? This figure is also from the same research and shows you a representation of the increase in the percentage of patients with at least 1 viral load per year. And we see that in the 7 countries, the viral load has really increased very sharply, which means that it catches up with the need to address the additional testing needs. So, however, behind these success stories, there are still some few gaps. And you see 2 figures that are being extracted from the UNAIDS report of 2020. And you see the percentage of people living with HIV who are virally suppressed, taking the denominator of every patient that know their HIV status. And we see that in Eastern and Southern Africa, 65% of all the HIV people knowing their status are virally suppressed, with 45% in West and Central Africa. It's lower, with some worrisome result, especially within men as compared to women. And so that really illustrates several problems. So the linkage to care might be an issue. Is everyone that knows the HIV status receiving the treatment? Is everyone on treatment receiving a viral load? And is everyone receiving a viral load virally suppressed? And these are the problems that come through the numbers that we see here. So if we examine the viral load testing cascade, and this is a slide that has been shared by Dr. Trevor Peter from the Clinton Health Access Initiative. And what the Clinton Foundation has done is that they have broken down the HIV viral load testing cascades in different steps, from the moment when the patient comes to visit the facility, the collection of the samples, the transport, the test performed, all the way to the clinical action when the result is known. And you see the first result down with the red percentage, and they look at what is the percentage of patients that are lost along the way. And they see that for viral load, 14% of the patients are lost, from the moment a patient comes to visit the facility and the sample collection. And then we see that in the later steps, there are very little information available to actually understand what is the itinerary of those patients. And it really touches upon the lack of monitoring system for viral load. When we look at the results down for early infant diagnostic, we see a dramatic loss of patients at the first stage of the viral load testing cascade, and we really don't have a clue what happens for the clinical action for these infants that are being tested. So still looking at those this viral load testing cascades broken down into different steps. What are the system issues that can affect the viral load at all these different steps? So we see the system that are underlying each and every step of the cascade, and we see the policy and regulation in the early steps, the sample referral system, quality management system, especially when we perform the test in the facility, the supply chain for the reagent, the laboratory clinical interface, and of course the workforce, which are all very important for a good utilization of the results. And there are a lot of weaknesses in those systems that are going to have some implication. And in the first steps of the viral load testing cascade, we can see that there's a poor demand of the viral load from both the patient and the clinician. In the facility, there are lack of SOPs to really do a reliable testing. There are issues with the sample referral system, poorly optimized work, lack of compliance to the guideline. A lot of issues are coming, which explain that the viral load testing is not optimal everywhere. So in order to scale up the viral load testing, it takes a combination of technical and non-technical solutions at facility and system level. And I would like to share with you some of those interventions that has been successful. So the first one is about the sample referral and the establishment of hub and spokes sample referral to improve access to centralized viral load testing. We know that capacity is very scarce in many settings of Africa, and it's a problem of sharing or accessing this capacity wherever a patient might be located. So this is like a representation of what a sample referral can be, and a lot of models for sample referral have been summarized by Dr. Fujungo and colleagues from the CDC in 2017. And here we see a system that is a centralized sample referral, whereas a central laboratory is going to take care of the viral load and other sophisticated molecular testing. And the samples coming from the periphery, which are the spokes with lower capacity, such as microscopy, basic rapid tests, the specimen and not the patients are then going to be gathered to hubs that have intermediate capacity and where tests like the CD4 count or test on the gene expert can be done. And then finally, the tests that really require molecular testing go to the central laboratory. And the advantage is really that then you can also centralize the supporting system, such as the quality assurance, the supply chain and the supervision to a central place and not overstretch the capacity across the network. So this kind of model has been implemented in Uganda already for a while with collaboration from different partners like the CDC and the USAID. And through the GIS mapping of the facility and the capacity across the country, Uganda has been implementing a sample referral whereby a hub of capacity is serving a radius of spokes within 30 to 40 kilometers. And by establishing 100 hubs, Uganda is capable of reaching out to 2,500 health facilities, and they achieve a 90% coverage of the testing needs for the HIV viral load. And the sample is transported through motorbikes, and a rider reaches 20 to 30 facilities that are under the catchment area of the hubs at least once a week. And they do the sample pickup, and they also do the drop-off of the results. Point of care testing is also a popular and effective way to simplify the viral load testing cascade. And why is that? It's because it collapses a lot of the different steps of the viral load testing cascade into a single visit of the patient. And that has the potential to eliminate all the loss points between the sample collection, the test performed, and the result return, because the results can be provided on the spot. And then the result return and the clinical action can also be done in a single visit. And there's a lot of technology that can support a point of care for viral load, but also for the CD4 count. So there've been a lot of evidence showing the benefit of the point of care technology in terms of increasing the percentages of patients that can start ART immediately after their viral load, and also the percentage of results that return that are used within the 60 days. But introducing new point of care technology can be lengthy, and we know what are the usual caveats for the uptake of this technology by the countries. There are unclear regulatory pathways. There's a lot of evaluation that can take care in the country before the product is allowed to be used. There's a lack of normative guidance in the sense that it's sometimes difficult for the country to use a point of care in a clinical setting as opposed to a laboratory environment. There are high prices, and there used to be a lack of long-term funding commitment from PEPFAR and the Global Fund, although this evolved since the past few years. So the Clinton Foundation, and they shared that slide with me, really gave a lot of guidance and orientation for the stakeholders and implementing partner on what kind of work stream do we need to conduct in order to accelerate the approval of point of care testing, make sure that it is established routinely within the clinical or laboratory activities. They've also strengthened the right system, the workforce, the supply chain. They have supporting global access pricing, catalytic procurement, and co-investments by global funders. There's also an interesting entry point to improve the scale-up of viral load, which is integrating the viral load testing on existing instrument and platform. And a lot of solutions have been collected through consultation with stakeholders and partners that have been convened by the WHO in collaboration with ASLM. And you see on this table the different platforms which have a large footprint on the African continent. And you see on the left all the different diseases that in theory those platforms can actually address. And they can address HIV, early infant diagnostic, hepatitis, multi-resistance tuberculosis, and HPV. So in theory, it's very attractive to think that those molecular platforms can be used to multitest so that we don't need to buy multiple instruments for the testing. So there's been some piloting of integration, and it's a different level of advancement in different countries. And what we can see is that the GeneXpert is a good candidate for integration because usually there's been a lower rate of utilization of the GeneXperts that are available through the TB programs. But however, there are sometimes fears about the TB program, whether or not including HIV would cannibalize the instrument and not be beneficial for the TB program. But in reality, the pilot demonstrates that when HIV and TB are integrated, there are no negative impact on the tuberculosis testing. There is a decrease of turnaround time, not an increase, sorry about that. And also the programmatic cost, they can be really a benefit in sharing the cost through the same instrument. And there's a good acceptability of the people that use the same instrument to do the testing. There are challenges on the ground. We need to adapt the workflow in the laboratory, sometimes organize shifts, also update the workforce capacity for the increased flow of patients and sample. It's a new technology. We have to prevent the overuse of equipment and of course respect the tier-specific recommended testing package when we recommend integration. How do we make integration work? And something that is very useful is to select the sites where integration or new instruments are going to be placed. And that's to ensure there's a maximum coverage of testing need and a maximum efficiencies. So all these interventions are summarized under what we call diagnostic network optimization. And that's basically working on GIS information or where the facility, the instrument and the capacity is located in a country. And ASLM and the Africa CDC have such a program that is called LabMap, where we triangulate this GIS information with information on the population density in a country and the road network to make sure that the best decisions are taken. An example of this kind of data is shown here on the right, where we see all the laboratory facilities and in Burkina Faso that are overlaid with population density. That's what you see in green. The facilities are the red dots. And behind that, we also have the road network. And you can calculate where integration or where implementing new capacity is most cost effective. We have our colleague from FINE that also have a similar system that's called OptiDX that focuses more on technology and that takes also sample throughput into consideration when they simulate where is the best place to conduct integration. And I put here for your attention a publication where you can read more about diagnostic network optimization. Another interesting intervention are viral load campaigns to increase the demand for viral load testing. And we collaborate with the International Treatment Preparedness Coalition from South Africa, ITPC. They have an activist toolkit because it's of course important that the civil society and the patient can demand for their viral load so that you increase the demand and the testing. So here you see where ITPC trains the country team to prepare their campaign. These are some of the results of this campaign. In Kenya, they had chosen for a hashtag campaign where they target the young population to demand to know their viral load. Here in the Democratic Republic of Congo, they also target the young population, the pregnant women, and also they do the campaign in local language. In Zimbabwe, they chose to have some material to know about the viral load that targets different key population, and they have really used social media and the radio to propagate their campaign, and that's really very important. There are other interventions really improving the return of results to clinician and patient through SMS. That's, for example, done in South Africa, Zambia, and Kenya, and it's partnership with the telephone company that has to send the SMS. There is the designation of champions at facility level. They can ensure the quick transfer of available results to the patient file, and the US CDC has nice framework and guidelines to implement that in the clinic. And something that is not typically thought about as an intervention is to manage the additional toxic waste that is related to the increased viral load testing. And that's implementing tools to estimate the amount of waste, increase access to incinerator, avoid that toxic waste is being dropped in the drain, and update the policies for biosafety with really nice examples from South Africa. So sharing good ideas and best practices, they exist for HIV care. And so how can we do that to accelerate the scale up of the viral load? Some countries we know have found better ideas in several areas to scale up the viral load testing. And we need to find a way to share those best practices, innovation, and implementation solution from one country to the others. So at ASLM, we have what we call the Laboratory System Strengthening Community of Practice. That's the LabCOP. And we work in all the countries highlighted in yellow on these slides. And what we do is we have participants that are country teams, that are a mix of stakeholders and discipline, to take different perspectives into account when we scale up the viral load. So these are people from the laboratory sector, policymakers, clinicians, civil society, implementing partners. And what we do is that we have those country teams that have interactive seminars online to share their experience. And we also help those countries with individualized country visits to discuss about the result and to really provide hands-on technical assistance. And we focus the area on what are really the priority for funding opportunities. So this is how, one of our echo session, online session looks like, with several people connecting, typically 100 to 300 people for each connection. And you see in the figure down there, we've done since the last 2 years, more than 40 sessions with 20,000 different connections, also spilling over Africa, especially because this model was very popular also to answer questions on the COVID-19. We had a lot of topics that have been addressed, as you see in the list, from result utilization, demand creation, return of results, and funding, which is really a topic that is rarely addressed. And we have a lot of different contributors from different horizons. So, and if you visit the website of the ASLM, you can find those presentations and the products of the discussion. So what does ASLM do within the LabCOP? We summarize the best practices and the discussion into what we call recipes on several topics that the country teams can use as really practical guidance. And what we try to do here is to offer the country not a menu, but how they can cook, let's say, a chocolate cake, if I would use that metaphor, so that they can really become very confident and implement solutions that are tailored to their specific context. What we do as well within the LabCorp is that we measure the gaps and the strength and the progress along the viral load testing cascade in the different countries. We use standardized tools, and what you see on the dashboard at the bottom is the different steps of the viral load testing cascade. Where are the gaps, and you see the red and the yellow colors is where most of the gaps are. And what we do with those results is that every year the data feeds into action plans that are targeted to those gaps, and we submit those funding, the countries submit those fundings to the PEPFAR and the Global Fund. And like that, we have really an evidence-based intervention that can produce results. So what are the take-home messages? So improving access to and utilization of viral load results is very important, and that goes beyond the laboratories. It should be thought in terms of network, interfaces, and systems. Systems strengthening intervention are key to the acceleration of the viral load scale-up. Many good practices exist across Africa, and they need to be shared to really accelerate the scale-up of the viral load. And all those lessons learned for the viral load are applicable for other testings that are relevant to the HIV program. And finally, very important, there has to be an alignment of the objective from the HIV program, the funding, and the national policies in order to have the best results. So this is my last slide. Thank you so much for your attention. And please, if you can, join us for the upcoming ASLM conference in 2021. Thank you.
Thank you so much, Professor Ondoa, for that comprehensive review of what's happening with your unit and what's happening across Africa. And there's so many lessons to be learned for this region from what work you've been doing. And we look forward to talking to you during the chat after the next talk. And it's with great pleasure that I introduce Dr. Anna Grimsrud, who's going to talk about differentiated service delivery for HIV and beyond. She is the lead technical advisor at the International AIDS Society. She's was trained at the University of Cape Town in South Africa. And whenever I think about differentiated service delivery, I think about Anna because she's done so much work to help develop this. And also she's on a number of national, regional, global technical working groups on HIV, which are basically she provides technical and strategic leadership on this differentiated service delivery. And I'm really looking forward to her talk on this subject now. Anna, over to you.
Hello, everyone, and thanks for joining us today for this session. I'm going to present for the next 15 to 20 minutes on differentiated service delivery for HIV and beyond. I'm going to spend the first part of this presentation talking about the concept of DSD for HIV treatment, describing the genesis of DSD, and outlining how DSD for HIV treatment has been adapted and accelerated during COVID-19. I will then close with some final thoughts on how differentiated service delivery is about more than just HIV treatment and where the field is going. Differentiated service delivery, or DSD, previously referred to as differentiated care, was defined in 2016 and part of the revised WHO guidelines for HIV. As shown here, DSD is a client-centered approach that acknowledges both the needs and expectations of various groups of people living with HIV or at risk of HIV acquisition. And it also acknowledges that the resource limitations of the health systems. It applies across the HIV care continuum from prevention through to viral suppression, quality of life, and to improve outcomes for those with advanced HIV disease and other health conditions. Now, this is an old slide showing the scale up of antiretroviral therapy in the first 10 to 15 years of the HIV treatment access. We realized huge success in reducing morbidity and mortality among people living with HIV. And one of these successes was the rapid and exponential scale up of access to antiretroviral therapy, or ART. In the year 2000, there were less than 1 million people on this life-saving treatment. However, thanks to strong global efforts, the involvement of communities and people living with HIV, activism, and international and national efforts, the global goal of reaching 15 by 15 was realized, and more than 15 million people were on ART by the middle of 2015. This was the first time in the history of global health that we reached a treatment target ahead of schedule. On this figure, you can see the tremendous increase in access, particularly among people living with HIV on the continent of Africa. Importantly, in 2015, the WHO updated their guidelines and recommended that all people living with HIV, regardless of their clinical status, be started on antiretroviral therapy to both improve the outcomes of the individual, but also to reduce the probability of onward transmission. This change in guidelines meant that all people living with HIV, or 37 million people worldwide, needed to access lifelong daily therapy. You'll recall that at this stage, there were 15 million people on ART. This was a huge accomplishment, but we needed to more than double the number of people accessing treatment. Another way to think of this is that there was a huge shift and a real acknowledgement that helped us to reach the first 15 million people with antiretroviral therapy, that how we did that was not going to be the way that we were going to reach all 37 million people worldwide. And in the words of Albert Einstein, the definition of insanity is doing the same thing over and over again and expecting different results. And so we had to do things differently, and differentiated service delivery was born. So 20 years ago, HIV was very medicalized. HIV drugs were expensive and they had a lot of side effects. And people only started on antiretroviral therapy when their immune system was compromised by HIV. A small number of people were seen by doctors, often at hospitals, not even clinics, and they were seen every month. Today, many people living with an HIV are involved in the self-management of their HIV care and only see clinicians every 6 to 12 months. Much of their care and antiretroviral therapy refills happen close to home, and visits to health facilities are infrequent every 6 or 12 months. So we need to talk about how, in this context, we can support the other health needs that people living with HIV might have. Differentiated service delivery, as I said, recognizes that we need to think about the person living with HIV, think about their clinical needs and what the specific populations that they're a part of and the context in which they live. And then we can adapt services, both to meet their needs and within a public health approach. We can adapt these building blocks that are shown here. We can adjust when they receive care or how often, where they receive care. Is it in the clinic, in a community, or in their home? Who is providing the care, including peers or clinicians, and what, the package of services. Within DSD, we adjust these building blocks to create different models of DSD for HIV treatment. Two of the earliest DSD for HIV treatment models were innovated in Southern Africa in response to different challenges faced by people living with HIV. In Mozambique, particularly in the rural province of Tete, the clinics were far away from where people living with HIV lived, and it was an arduous journey to access them. In addition, there were limited supplies of antiretroviral therapy. And so community adherence groups were born. Community members got together, they formed a group, and they took turns making the journey to the clinic. When it was your turn to go to the clinic, you would have your clinical consultation and pick up ART refills for everyone that was part of your CAG, and then return home to the village and distribute them to the members of your group. These groups were known as CAGs, or community ART groups, and they've shown positive outcomes with great retention and viral suppression, as well as reducing costs, especially for people living with HIV. Meanwhile, in South Africa, the challenge was for more demand, and the need for antiretroviral therapy to expanded with overcrowded clinics and challenges with retention. In response, healthcare workers set up adherence clubs, which were groups of 15 to 30 people who were established on treatment. And they would meet as a group to have appropriate treatment literacy for someone who is stable on their treatment and to receive pre-packed antiretroviral therapy. These clubs would meet every 2 to 4 months, but only see a clinician every year. Outcomes for club patients are also really, really good. And the model was scaled up across the Cape Town Metro in the Western Cape of South Africa, with over a quarter of the people in an adherence club by the end of 2015. Here's an example of a DSD for HIV treatment model using the building blocks. These are postnatal clubs for women. Critically, note how the building blocks are different for ART refills, for clinical consultations, and for psychosocial support. In some instances, the maternal newborn child health nurse is engaged, and at other times, a lay provider or a mental mother is the person who's providing the services. It's important to separate out these different types of services because the building blocks might be different in terms of being offered at a different location, at a different frequency, and by a different cadre of staff. Today, the World Health Organization recognizes 4 models of DSD for HIV treatment shown here. The first 2 on the top are the group models, similar to the ones that I've just discussed. In the top left, group models managed by a healthcare worker are like the adherence club presented, and they can take place at a clinic or outside of a facility in a community venue, such as a church or a library or a community-based organization. On the top right are groups managed by clients themselves, such as CAGs from Mozambique, where the group is managed by people living with HIV. There are also individual models. On the bottom left, you can see individual models based at a health facility, and on the bottom right are individual models not based at health facilities. So these would be things like community distribution points, collection from private pharmacies or drop-in centers, or via community collection points or outreach. All of these models are enabled by longer ART refills, or MMD, multi-month dispensing, but this isn't essential. And in all of them, the clinical consultations are considered separately to the ART refills. Countries use different names for these models. So group models also include things like family clubs and teen clubs, and community ART refill groups and client-led ART delivery. And the individual models outside of health facilities also take many forms, such as community drug distribution points, external pickup points, drop-in centers, private pharmacies, and home delivery. Now, these models have been adopted by many countries in sub-Saharan Africa. Using South Africa as an example, the National Department of Health defines 3 DSD for HIV treatment models, which they call repeat prescription collection strategies. These are facility pickup points, or an individual-based model at facilities, adherence clubs, a group model managed by healthcare workers, and external pickup points, or an individual model not based at the health facility. As of the end of June in 2021, there were 2.4 million South Africans accessing their antiretroviral therapies in one of these models. And of these, 1.4 million were collecting refills from an external pickup point. And there were 2,781 of these pickup points across the country, things like private pharmacies, community points, lockers, etc. Also very importantly in South Africa, HIV care is not in a silo, but is part of the National Adherence Guidelines for HIV, TB, and NCDs. And so people can also access their hypertension and diabetes medications through these repeat prescription collection strategies. Now, DSD for HIV treatment is for everyone. And earlier this year in April, the WHO revalidated and added more guidance on DSD for HIV treatment. The WHO recommends that people who are established on antiretroviral therapy can be offered clinical visits every 3 to 6 months, and that these same people can be offered 3 to 6 months of ART, preferably every 6 months if feasible. The guidelines also redefine how we define someone as being established on ART. And this definition has been adjusted from previous guidelines when we discussed clinical stability. So for someone to be eligible, they need to be on treatment for at least 6 months, have no current illness, have an understanding of lifelong adherence, and have evidence of treatment success. In other words, this definition includes all populations. It includes those on 2nd and 3rd line regimens. It includes those with controlled comorbidities. It includes everyone regardless of age, so children and adolescents are also eligible. And it also includes people who are pregnant and breastfeeding, as well as key populations, gay men and other men who have sex with men, sex workers, transgender people, people who inject drugs, and prisoners and others in incarcerated settings. Now, COVID-19 has led to exciting accelerations in the implementation of DSD for HIV treatment, as well as to adaptations to respond to movement restrictions and limit unnecessary interaction with the health facility. And so DSD has really been a mainstay of HIV programs in response to COVID-19. We've seen adaptations to DSD for HIV treatment into these 4 categories. All of these are strategies to limit visits to health facilities and to ensure uninterrupted supply and access to ART. First, we've seen rapid changes to the eligibility. Second, we've seen that many countries have increased the duration of ART refills or multi-month dispensing, or they've also reduced the frequency of clinical consultations. Third, community-based models of HIV care have been emphasized. And finally, there has been some policy shift towards supporting integration and alignment of HIV services and commodities for other health conditions, including TB preventative therapy, common non-communicable diseases, and family planning commodities. Recently, we've looked at current national policies related to DSD and HIV treatment and developed a series of policy dashboards, which you can access at differentiatedservicedelivery.org. There are 13 policy dashboards that track policies in 33 countries. In addition, these policy dashboards look at how countries made different provisions during COVID. And these dashboards focus on changes to eligibility criteria, changes to the duration of ART refill and frequency of clinical consultations, integration with other services, and on community-based models. So I'm going to talk a little bit about some of these dashboards now. So here's the first dashboard and what they all look like more or less. So in the teal ovals, what you can see are national policies looking at whether or not pregnant and breastfeeding women are eligible for DSD for HIV treatment. And the orange ovals highlight policy changes in response to COVID-19. So you'll note that the majority of countries explicitly exclude pregnant and breastfeeding women in that column on the left. But in some countries, this population is eligible once they're established on treatment before pregnancy. And in Ethiopia, you'll see that both postpartum and pregnant women are eligible for 3 months of antiretroviral therapy, a policy adaptation made in response to COVID. And here's the data from Ethiopia to show the impact of this from May to October 2020. So here you can see that the number of women receiving 3 months of ART refill is in purple, and the number receiving less than 3 months is green. And over time, the proportion increased from 68% receiving more than 3 months to 92% receiving more than 3 months. Here we look at the amount of time on ART before somebody is eligible for DSD for HIV treatment. And you'll notice how many countries changed their policy in response to COVID with all of those orange ovals on the left-hand side. So before COVID, most countries required 6 or 12 months on treatment. But in response, a lot of countries allowed multi-month dispensing right from treatment initiation. In data presented at IAS 2021, the IAS conference on HIV science this past July, there was data from Zambia that showed the impact of earlier initiation into these models and showed no difference or improvements for those who initiated in DSD for HIV treatment before 12 months compared to those after 12 months. And hopefully soon we'll have data on the impact of ART, extended ART refills from ART initiation. Next, here is a dashboard that looks at the maximum duration of ART refills allowed. And so on the far right, we see 6 MMD or 6 months of treatment. And this is something that was very rare a couple of years ago and is now the national policy in a number of countries. PEPFAR partners have started reporting on the duration of ART refills. And in this analysis that's in press from 21 PEPFAR supported countries, the duration of ART refills from October 2019 to December 2020 is presented. In red are refills less than 3 months, in green refills of 3 to 5 months, and in purple 6 months of dispensing. By December 2020, 6.2 million people supported by PEPFAR, or 53% of the cohort, was receiving 3 to 5 months of treatment. And 2.5 million were receiving 6 months of treatment at a time. And so in this 15-month period, there was an increase from 49% to 75% of people receiving at least 3 months on treatment. Now, this trend towards longer ART refills is also being seen in children and adolescents, and this is really exciting because they're not being left behind. In this data presented at IAS 2021, you can see an increase from October 2019 to a year later from 34 to 55% of children and adolescents receiving extended ART refills. And so we're glad to see children and adolescents as part of this. This shows community models that are supported in policy. And again, you'll see that a number of countries started to offer and emphasize community models in response to COVID. In Thailand, the Institute of HIV Research and Innovation, or IHRI, supports key population models of DSD through community-based organizations. And what happened during COVID is that refills were done via mail with telehealth support, and the majority of psychosocial support and viral load testing were transitioned to being in community-based organizations instead of in the hospital. In many places, community-based organizations and peer providers work tirelessly to ensure uninterrupted ART through home delivery, by courier, by bicycle, by peers. And in the Philippines, the Jack Anta program utilized an online platform for people living with HIV to have their ART couriered via motorcycle. Between April and August 2020, more than 7,000 people received their ART delivery at home via this mechanism, and this represented more than a quarter of Indonesia's total treatment cohort. Finally, this dashboard shows the integration of TB preventive therapy, or TPT, within DSD for HIV treatment models. And unfortunately, you can see that the majority of countries don't specify if TPT can be included. My example here is in Zambia, where a pilot project worked to include 6 months of TPT within the fast-track DSD model. The pilot showed high feasibility, acceptability, and uptake, with over 90% of the people completing their 6 months of TPT in this model. And this is now national policy within Zambia. So just briefly, I want to make the point that DSD applies across the HIV care continuum, including for PrEP, so we can adapt these building blocks for PrEP as well. Using the example of G-Link from Vietnam, they've increased mobile delivery and online support. They have PrEP providers who are part of their cadre, and they offer both event-driven as well as daily PrEP. So what's next? Where to from here? First, we need to ensure that many of these adaptations to DSD are retained beyond just an emergency response to COVID and are part of building back better. A silver lining of COVID is that countries were pushed to try new innovations, and now we should consider if these should be retained. Second, DSD is not just about HIV treatment, and it's not just about HIV. We need to transition to a more person-centered approach and support self-care for complementary health services. And this is a logical path towards sustainability. And so while some strides have been made with integration of TPT and NCDs and family planning, more needs to be done. There are minimal efficiency gains for people or the health system if they can receive their HIV care and support 6 monthly in their community, but they need to go to the facility every month or two for injectable contraceptives or for hypertension medications. And third, much of what I've presented today, both in terms of policy and implementation, is from sub-Saharan Africa. However, DSD for HIV has a role and potential in other contexts. And so hopefully by sharing with you, more can be done to think about how DSD can contribute to the HIV response in your context. Thank you for your time, and I look forward to your questions. Please visit differentiatedservicedelivery.org for the latest news, events, evidence, as well as tools, policies, and resources to support implementation. Thank you.
Thank you very much indeed, Anna, for that wonderful description of what's happening in Africa with DSD. And as you say, it's could be used across the globe. And in fact, even here in the UK, we've been using forms of DSD in terms of home delivery and access to communities through an adapted way of doing DSD. But I just wanted to start with you actually and ask you the opportunity for what Eamonn was speaking about reducing stigma and discrimination, because when in the project that I lead in Tanzania, when people get together in groups as part of the DSD, we try and give them some sort of educational information. And I just wondered whether you've what's been happening with that to try and inform the HIV community who are meeting together in DSD groups about how to deal with discrimination and stigma, because a lot of stigma is actually self-perceived, and I think that might be an opportunity for these sorts of structures to help.
Absolutely. Thanks very much, Anton, and thanks for relating it to Eamonn's presentation around stigma and discrimination. So I think you make a very strong argument that part of treatment literacy and HIV education has to be around this transition towards a degree of self-care and self-management for HIV, and acknowledge that there's different types of stigma, like you mentioned, self-stigma, as well as discrimination. So speaking in general, we see that there are populations that really benefit from having peer providers play a substantial role in their HIV care, treatment, and support. And so linking people in a group to a network of other people living with HIV is very important for some people at some phases of life. We see this particularly for adolescents. We also see it for men, and we see it for specific key populations. And there is some data from Tanzania actually around female sex workers and how them being part of a differentiated service delivery model for HIV treatment did reduce their HIV self-stigma. I think when we look at other key populations, we need to consider the extent where there is criminalization. And when we look at where services are provided, people need to have a choice to understand how close to home having services is or is not a good idea. And again, we saw this in some data at IAS 2021 and data from India, where some key populations did want care and treatment at home, whereas others wanted to still be able to access it at a health facility. And this was due to they not necessarily having disclosed to the people that they live with and wanting to access services outside of their house or outside of their immediate community. So I think that a key kind of takeaway message here would be to ensure that people do have choice, because at different phases of life and depending on different challenges, a different model of service delivery is going to work best for them.
Yeah, that's really interesting. Just to say, the live audience in Beijing, please come to the microphone and ask questions. If you have any, we can, we're here for the next 15-20 minutes to answer questions for you. And obviously, we have the online chat where we can look at the questions. Eamonn, there seemed to be quite a lot of ground that you need to cover in the next few years to get to these targets. And you did talk about conservative societies and the difficulties there. What do you see the principal challenges, especially where there's criminalization going on? Do you think that there's a role for UNAIDS in that respect, in trying to promote advocacy and moves towards relaxing rules that are stopping us achieving these targets?
Thanks very much, Anton. And the context of COVID has also brought this about. Anna was just talking about the issues of multi-month dispensing, DSD in the previous presentations. And when during COVID, people had to return to their homes because some of the greatest impacts of COVID has been socioeconomic. Obviously, there's the personal health and death that's significant, but people have lost jobs all over the region. And people who are in at key risk of HIV or are living with HIV have had to return to homes or to settings where they may have had increased fear about disclosure of their HIV status. And this is where issues like access to medicine and differentiated services are critical. And UNAIDS, as in the full partnership, working with partners, IAS, of course, is another key partner in this, the World Health Organization, UNFPA, many of the UN partners that are part of UNAIDS need to be addressing this. That's why the new strategy is very much focused on the inequalities. And especially as we're trying to get past in some countries where they've had some success at treatment coverage, prevention services, it's the remaining numbers, the last miles is often used as a term for those hardest to reach. They're the ones who suffer the most inequalities. And we've seen that exacerbated and just repeated with COVID for other populations, but including those at risk of HIV. And so this is why it's going to be critical for us all to work on a reframing around this. global strategy, focus on inequalities, the new political declaration, which is even more powerful in the sense that member states themselves voted this year and reaffirmed their commitment. And they put the 10% targets, including all those reductions of criminalization, reductions of stigma and discrimination, violence, including gender-based violence for women in parts of the world, including PNG in the Pacific, in sub-Saharan Africa, of course. So all the different elements, but the programs will have to be tailored, because in some countries we're seeing politicization of certain issues like sex between men, right? And so that's going to take a whole different strategy than you would through the health system. So this is why we need the range of partners to be involved in this. It has to be a top priority, because that's what's holding back and actually setting back some of the responses in countries where people are now too afraid to go to a fixed site health service for fear of being registered or identified by a certain behavior, which is where the virtual space, the innovations that we can see coming in as part of the DSD programs in many countries in our region, that will help both for access to self-testing, online services, PrEP on demand, as Anna was just saying, is another way. So you don't need to access the services. And many of the people we need to reach now are much more literate in the virtual space than they were at the beginning of the response. So it's definitely a priority across the region. I don't think there's a country where we don't need to see a change around this whole policy on stigma, but U equals U is going to be a critical part of that as well, to see the benefits for early initiation to treatment and the support for sustained adherence, and take away self-stigma as well as stigma in society as people understand that whole dynamic differently. Back to you, Anton. Thanks.
Thank you. Thank you very much for that. I mean, Pascale, coming on from what Eamonn presented in his presentation about resistance issues. How do you see this playing out, not just in the African region, but in other regions where there are lower middle income countries where resources are not so well funded, maybe by international organizations, by PEPFAR, et cetera, and you've got to do resistance surveillance. I mean, in Africa, how does that sort of work, and what model might you think could happen elsewhere? I mean, for my country, everyone can get a resistance test. You know, it's because the resource in terms of funding and the ability to get it done is there, but you can see, especially in Western Central Africa, that's not the case. How could you just give us your views about how you would see surveillance ongoing to make it more accurate and more specific?
Yeah, thank you, Anton. So first of all, I think that yes, the resources are very, there are a lot of constraints. So still continue to make sure that the viral load and the identification of virological failure is actually done, and so that as few as possible HIV drug resistance would emerge anyway. So that would be my first recommendation. So there are some countries that do have a lot of HIV drug resistance, and I would mention Kenya, for example, who doesn't wait for programs to fund them, because they have a lot of patients that need to go from second to a salvage regimen and third line, and they do HIV resistance testing. It's still going to be quite a challenge. And I think I would turn the question around and really, because it's a public health approach, it would be nice that the recommendation on what to do from a public health perspective when the results of the HIV drug resistance are there, and not only describe them as being, okay, they are higher than 5%, higher than 50%, what concretely does a country do so that the investment case for HIV drug resistance is clearer, would be really great. But one interesting avenue is also all the capacity that is now being put in place for the COVID-19 and the identification of variant of concern. So there's a lot of equipment and instrument and capacity for next generation sequencing. And I see that as, you know, probably an avenue so that this capacity can then be used for HIV drug resistance and can be used for the HIV program. I think that's very promising.
Yeah, I mean, I think it's fantastic that we start to change our view of COVID as a challenge into an opportunity for the future. While you're still there, there's been several questions in the chat, but one from Dr. Tassimbedu, who's saying basically that Gene Expert's a fantastic platform, but it's sometimes difficult or impossible for local systems to afford it on a regular basis, especially the reagents, et cetera, are there, like we did with HIV drugs, etc., I'm asking you, are there ways of having a sort of Gene Expert generics which would make it much more affordable?
Yeah, so that's a question that of course has a multifaceted responses, and the Gene Expert is a very interesting technology because it can be placed, you know, at community level, or at least that's what we are made to understand. It's a point of care. However, when you outreach the community with an instrument, it's like almost you have like a mobile lab that needs to, you know, to be moved to the community, and that comes with all sorts of system issues. The price is one of them. Once you have sorted out the price, then you have to sort out all quality assurance around the testing, whether or not the supervision of the staff is there. So that's one aspect of the supporting system that are not always accompanying the test. So I think the response is in, yes, there can be global negotiation to decrease the price of tests, like it has been done for the HIV treatment. I think that from the country perspective, it would be nice to see the cost of a test in regard to the public health and the clinical benefit. It's not only just an absolute cost, but what do you gain in terms of a good viral load testing? I think it would be nice when the country consider that, so that when they dedicate the budget for the test, for the reagent, they really see that it's very important. Now, when we place those instruments on the ground, it's important that we place them where they are most needed, so that the volume of testing can really be large enough, so that, you know, there can be some bulk procurement and decrease of the price of the testing. So all of this needs to be taken as a holistic activity, whereby you have the Ministry of Health, the facilities, and everyone being very responsible of, yes, I can put a machine in the community, but is it sensible in terms of supporting system and in terms of procurement?
Yeah, we've all bought things thinking they're wonderful and then put them in a cupboard. Yeah, so it's it's the same when we look at that. But I must say that this technology seems to have transformed the way that we manage HIV. Anna, one of the themes that have come in all the talks is around the way that we've been starting to work remotely because of COVID. And there's a question on the chat about the role of telemedicine and differentiated service delivery. And I was just thinking, if I was one of the peer support people, I could peer support people through mobile phone technology or whatever, or computers. Was that happening very much?
It's a great question, and I do agree that it's been kind of one of those innovations that's been nudged to accelerate at a different pace in response to COVID. I think what's also interesting in this regard, and you've alluded to this as well, Anton, is telemedicine is something that has become more prolific in all sorts of resource contexts. So we see some great DSD models actually emerging from the United States with Veterans Affairs in relation to telemedicine. So a nice job of kind of debunking this idea that DSD is just for low resource settings. I do think there's a huge role for components of telemedicine and components of virtual support. And I think also what we need to do is acknowledge that there is still a real data divide in terms of access to the ability to utilize mobile phones and how expensive data is for many people. And I think, you know, speaking more in a sub-Saharan African context, we pay more for data than anywhere else in the world. And we also have the highest burden of HIV. So I think we do need to consider how we can support access to information and access to virtual support. And that is going to also have to acknowledge the costs to do that. And acknowledge whether or not we can ensure that our peer providers also have access to data to do those things. So I think we do need to look to virtual to be complementary, and that we need to make sure that we just like Pascale was talking about, there's an access thing here as well, right? This isn't just everybody being able to do this. So we also need to see how we can build that in, and at what stages telemedicine makes a lot of sense. So some of the data that I showed was from Thailand and really showed how, you know, you could initially initiate someone on treatment with a healthcare provider, and then subsequent follow-ups were done over the phone so that people didn't have to access the healthcare facility. So I think it's not exclusively to replace in-person visits, but there's some kind of combination that acknowledges the connectivity of the communities you're trying to reach.
Yeah. Well, we're connecting here with various places around the world, including Beijing. So please, Beijing, if you have any questions, you can ask that, but come up and ask them. Eamonn, you know, one of the things about policies given out by big organizations at UNAIDS is the reach. And I would think that telemedicine would be a huge opportunity for you to have a much bigger reach with meetings, with organizations, with that you couldn't in the past very easily do it in person. But now the affordability, apart from what Anna was saying about data, of being able to reach people through telemedicine, I mean, it must be an opportunity for you.
Thanks, Anton. Yeah, certainly with the use of the internet and the access in this region for large parts of the population, but not all, of course. And so that's a challenge. We do need that differentiation because there are many who can't afford the access or the technologies required. But we have seen great innovations in places like Manila, where telemedicine is being used for a whole range of services, including HIV, as well as combining it with the other support services, which are critically provided by the community organizations. You know, and so that's a mix, a part of the mix we need to make sure, because they themselves, and Anna was touching on this, need to be skilled in how to provide services in the virtual space. And G-Link, I think it was the example from Vietnam. Some amazing information coming up, both in terms of looking at statistics around numbers of young people who have never accessed a fixed site service for HIV, but have clear risks. And that's been found through the surveys they do with peer-to-peer young people online. Then they get them into services, get them tested, get them into whichever program. Better prevention services, get them into treatment if needed. In Mumbai, you can go in and Humsavar Trust is another good example of a partner where you can get a home delivered by motorbike self-test kit, and then you get the online counseling. So definitely there. Yet we have plenty of countries, unfortunately, where the vast majority are not going to be able to access this. But definitely the healthcare providers are increasing the level of support here. And that also then helps with moving it away from a doctor-focused service. And so we're getting allied healthcare workers, not just nurses, involved in this whole program. And the other part of all this, of course, then is to make sure we have a stronger program on stigma and discrimination reduction in the healthcare settings. Thailand has great models, and they start with the guards or the staff at the gates to the hospital compound and work right back upwards, because it's anyone you interact with who has some idea about how what HIV might mean or why you're there for services is important. So this is good. It's been modeled in Malaysia and a number of other countries, China, so all taking on different aspects and doing it. But the telemedicine is critical, but we need to bring the different components together, and that's going to be crucial for us to see, not just for HIV, but just like HIV now. Many of my colleagues I work with on HIV for years in this region are now leading their responses to COVID. You know, that's not a surprise given the capacity they built over time with lots of institutional strengthening capacity of their services and their understanding of that community public health and health literacy engagement around this. So telemedicine definitely the way to go as part of the virtual space. Thanks, Anton.
Pascale, can I just come over to you towards the viral load? I mean, and it really links into U equals U and what Anna has been saying about qualification to go to DSD and how important that is for us to get right, and how far or close we are to being able to do viral loads as a point of care test that people could just either do themselves or do much closer to home than come into clinics. I just, in the last minute or so that we got a questions, I just wonder whether you would like to expand on that a little bit, because I think that would be a game changer.
Yeah, thank you, Anton. So as I mentioned, there is point of care technology, and when we say point of care, is actually point of need. So that really, I'm not sure that we are at the point where a patient could do that as a self-test, because from a technological point of view, I think that the viral, you indeed need to make sure that your undetectable is really undetectable, and you know, you cannot transmit, and really that threshold, whether you're undetectable is that you have 0 copy of the virus, or whether you are lower than 10 copies, etc. It's still, I think it's still a barrier to really use that as a self-test in a very safe way. But as far as I can see, I think that the point of care is already quite a step, you know, to bring the testing close to the patient and close to the needs. So even used in a clinical settings, if all the supporting services are there, like the supply of reagent, making sure that there's quality control, and we know that at the end of the day, the laboratory services are still supervising how the point of care are being done at community level. I think we are very close to have a test that is near the patient and allows the quick triage towards differentiated care services. But
I suppose, Anna, that would be great if pharmacists or your peer support people in the DSD clinics could do that for the patients. It would really cut down a lot of issues, and it comes back to Eamonn's point about U equals U. You could reassure them about a lot of different things in terms of transmission and their own health. So any final thoughts on how, I mean, we've really moved into the future with telemedicine and maybe this point of care to help DSD. Do you think that would transform DSD a little?
I think it can, and I just wanted to pick up on the point that what these do as well as allow us to reach people we weren't reaching before. So it helps us around reframing this narrative. People are not hard to reach. We just don't know how to reach them. And I'm optimistic that some of these things will afford us being able to connect with communities and people that previously our health systems weren't designed to do. So kind of leave on that optimistic note. Thanks.
Thanks. No, I like that. People aren't hard to reach. It's just we've got to find a way to reach them. That's an excellent thought. I'd like to thank all of the panel for a great conversation. We could be going on for a long time, and I'm really grateful for all your time and your expertise, and wish you well in all the endeavors in the future, and for the region that we can get close to these targets on time. And thank you from Africa for all of the learning that you've shared with us today. Okay, thanks very much indeed. Okay, so everybody who's listening, we really do value your feedback. Please fill out the session survey and the post-meeting survey afterwards. And there are enduring materials, which means that all the presentations will be available on demand on the Livestream platform after the meeting. So use the same login credentials to access the materials, and that'll all be there for you to have a look at and review.